Welcome to the American Association of Critical Care Nurses Voices in Nursing podcast, exploring critical care nursing through meaningful and inspiring conversations. This episode is sponsored by the ECMO course, providing nurses with a comprehensive understanding of extracorporeal membrane oxygenation, with information available at www.aacn.org/ECMO-course. Now, here are your hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and Clinical Practice Specialist, Andrea Schmidt.
My name is Herb Williams-Dalgard. I'm the Learning Excellence Director for AACN. I also happen to be the producer of our podcast, Voices in Nursing. You're in for a treat today. This is our very first live recording of our podcast. So yeah, you are our first live audience. Today's topic is Beyond Sedation, Reimagining ICU Care through the ABCDEF Bundle. There will be an opportunity to, at the end of this session, for questions. We know that you're going to enjoy this session. Hopefully we'll answer some of those questions for you here today. And so without further ado, I will say, as I do at the beginning of every podcast, welcome to the American Association of Critical Care Nurses Voices in Nursing podcast. Please join me in welcoming our hosts, AACN's Chief Clinical Officer, Dr. Vicki Good, and our Clinical Practice Specialist, Andrea Schmidt.
All right, good afternoon, everyone, and welcome to this special live podcast recording here at AACN's National Teaching Institute in San Diego. I'm Dr. Vicki Good, AACN's Chief Clinical Officer, and I'm joined by my co-host, Andrea Schmidt, one of AACN's Clinical Practice Specialists.
Welcome to our first NTI podcast.
So today's conversation is about something many of us are deeply committed to, but that still challenges our tradition, culture, and practice in the ICU across the country: awake and walking. When I first heard about awake and walking, I have to say, because I'm a little bit of a seasoned nurse, I was like, you've got to be kidding. I cannot believe that you would actually do this. But it is proven to be incredibly beneficial, and you're in for a special treat today, because we're actually going to meet a patient right here that experienced awake and walking just a little over a year and a half ago, believe it or not. So, Andrea.
So today we are very honored to bring together three powerful voices who represent the science, the practice, and the lived experience behind this work. First, we're joined by Kaylee Dayton, nationally recognized expert and tireless advocate for awake and walking. Her work has helped clinicians rethink sedation, mobility, and what is really possible for ICU patients. We're also going to hear from Kaira Miller Becknell, a nurse who has taken this philosophy off the pages and into real-world practice. She's led, implemented, navigated barriers, and shown what it looks like when teams commit to doing things differently. And finally, we are very, very grateful to welcome Molly Kratzer. She's an ICU survivor who brings the most important perspective of all, and that's the patient's voice. At 23 years old, Molly found herself critically ill in the ICU. Her experience reminds us that behind every protocol and every bundle and every decision is a human life, with a life waiting on the other side of critical illness. So we hope that today's conversation is going to explore what it truly means to keep patients awake, walking, and engaged, why this work matters so much for outcomes, humanity, and hope. So thank you for being here and for the work that each of you does every day to reimagine critical care.
So I want to start the conversation with Kaylee. For those of you that are new to the concept, how do you define awake and walking ICU, and what outcomes have surprised you the most with this technique?
An awake and walking ICU is an ICU that only gives sedation when there is an actual indication for sedation, meaning that mechanical ventilation is not an indication for sedation. Certain indications include intracranial hypertension, status epilepticus, the inability to oxygenate with movement. Otherwise, patients are awake once that paralytic wears off after intubation, communicating, and as soon as appropriate, performing their highest level of mobility. And there's no family visitation restrictions. Families are part of the ICU team. And for me, I was born into that kind of environment. In 2012, that was one of my first in-hospital nursing jobs. So I knew nothing else. And I didn't realize the impact of those interventions. To me, it made sense because patients are human. So why wouldn't they be communicating their needs during one of their most critical, vulnerable, and potentially final moments of their lives? Why wouldn't they be moving around, awake during the day, sleeping at night? So I never questioned it. When I became a travel nurse, I got sucked into a different environment of automatic sedation and immobility, and I falsely trusted that what was normal was benign, and I'd never been taught why we did what we did in my first ICU and why that was so beneficial. And so now, looking through the research that's been going on for decades, it's amazing to me to realize that that is life-saving. We know with ABCDEF Bundle, which was really inspired by my home ICU, when they implemented that throughout 68 facilities with over 15,000 patients, 7-day mortality decreased by 68%. And they weren't even fully compliant yet, right? And they found that it's dose dependent.
Right.
The more elements of the bundle you receive, the less sedation patients get, the more mobile they are, the more likely they are to not only survive, but things like delirium decreases by 25 to 50%. And we think about delirium increasing the risk of long-term cognitive impairments, no matter a patient's age, by 120 times. That is not only life-saving, but it saves quality of life, which is really what I know that we as nurses care about. It improves discharge straight home rather than to a care facility by 36%.
Right.
Improves readmission rates to the ICU by 46%. And again, that's on a very low average. So for me, it was humbling to read these things after I had been a travel nurse, wishing that I had known those things. I had some intuition. I missed my home ICU, and I thought it was just because that was familiar. But by the end of 2 years of traveling, there were things that I could identify. I missed human connection. I felt like maybe these patients were different because these were, and excuse the kind of crude terminology, but for me as a 24-year-old, I was like, these patients are zombies. I missed communication and the sacred interactions that I had with patients in my home ICU. So when I went back, I immediately, without knowing the statistics, I immediately was like, oh, I love the way I feel here, the nurse that I am here, the interactions that I have, and I love watching my patients walk out the doors. I couldn't have told you why they couldn't in the other ICUs. But that was really shocking to me, to put numbers to those instincts and discomforts and anecdotal experiences that I had as a nurse.
It's amazing. And it's funny because I have now a 26-year-old pharmacist in my family, of course, who thinks she knows everything, which that's the way it's supposed to be, right? And I tell her what I did when I was a bedside critical care nurse, we'll just say a few years ago. And she's like, really? You guys did that? So it's just amazing what we're doing now. So Andrea, go ahead with your next question.
So we know what's ideal, and then there's what's real in some organizations. So I'm curious, where is the ICU community as a whole with adopting the ABCDEF Bundle and the Awake and Walking, because we know it's so very important. So what are things looking like across the country? And what are some of the gaps that you're seeing if they're not able to implement or execute?
I think we as nurses can appreciate that documentation has been a huge focus. Tracking these interventions are very important, but when we look at the accuracy of our documentation and what's actually happening at the bedside, it is quite jarring. And we can appreciate that before COVID, when the bundle was the hot new thing in the 2010s, we were making progress, inching our way towards Awake and Walking as a standard, but then COVID hit and we lost a lot of those experienced nurses. We were also in a very dire situation, and we kind of ran back to practices in the 90s. So here we are years after with this standard culture that was, again, resembles the 90s, where nurses that came in during COVID learned COVID care. And now they're kind of passing it on to the next nurses. So I see a trend of hospitals, units, leaders being like, we know this is wrong. How do we fix it? How do we go? A lot of times they say, how do we go back to where we were before COVID? But only when you look at that huge ABCDEF Bundle study with over 15,000 patients, only 8% of all those patients actually received all of the elements of the bundle. Only 12%, intubated or not, were standing bearing weight. So I invite people to think, okay, yes, we were doing better, we were doing less harm before COVID, but we weren't yet doing the most good. So how do we now move forward into the future doing even better, even more good? And the current research, even from the past year, one study looked at over 10,000 intubated patients and found that 75% were deeply sedated, despite orders for light sedation. So it was 2.8 times the amount of patients that had deep sedation orders, which is really scary, meaning that our RAS documentation is not accurate. So we're still grossly over-sedating our patients. Another study recently looked at multiple facilities and found that less than 10% of intubated patients got out of bed. So our mobility is very behind, which was also seen in that ABCDEF Bundle study. So we have a lot of opportunities. The exciting thing is that now we have greater opportunities for education and information dissemination. We see social media. Like I personally can feel a shift in the winds. When I started talking about this, ironically in 2020, I was met with a lot of hostility. And I feel like there's a lot of hesitation, but there's not hostility. That nurses are becoming more educated on the benefits of it. They're willing to try it. But then there's the question of how do we make that huge transition?
So I have a follow-up question. Do you think that some of it is the fear of having patients with no sedation and what they might be feeling? That may be part of it, but then the other part of it is not maybe utilizing the tools they have or making it maybe more difficult than it really needs to be. Do you think that's some of it?
Yeah, I think it's multifactorial for sure. And the fear and hesitation is so relatable because as a travel nurse, I remember hitting one of those pilot groups in one of my assignments, and I was told by the charge nurse, oh, hey, welcome to our unit. Here we did this annoying thing at 5 a.m, turn sedation off. When you start to see them flail all 4 extremities, that's how you know they haven't had a stroke, that they can't tolerate the ventilator, turn sedation back on, and chart failed awakening trial. And so I was scared at 5 a.m. by myself in a dark room, especially in a unit where I didn't know anybody, couldn't call for help, and patients really did come out so crazy. It was really scary. And my one job was to keep the tube in, and there was no other way. And so I definitely empathize with that because that has been the approach historically. Because if you look back into history, early 2000s, it was all about awakening breathing trials. So if that's still where we're at, then we're setting nurses up for that kind of scenario. And so if that's their only experience of turning sedation off is days after having sedation running, causing delirium, then there's no way any nurse is going to be like, that sounds fantastic. Let's do it with everybody. So that's part of it, is the limited experiences when they've never had the experience of turning sedation off shortly after intubation, preserving the patient's cognition, fine motor skills to communicate, to know what's going on. They're going to have that fear until they experience it themselves. Mm-hmm. And then we don't utilize our resources, meaning I am friends with the therapy community, the rehab community, and they come to the doorways and they're ready to work the patients, and they're either too sedated or sometimes the nurses will block the doorway with good intentions trying to protect patients, but they'll say things like, they're too sleepy to work with therapy. They're too confused. They're too agitated. When really those therapists are the SWAT team to treat those things, the underlying reasons for those things, to help us with the behavior management. But we as nurses don't always know that that's the benefit of it. We just know that they mix up the lines and then they leave them in the chair and we have problems with that, right? So it's understanding what everyone's roles are. RTs have a big role to play in it, but when the vent's going off, we feel like we have to run to sedation. Instead of encouraging the RTs to use their magic, sometimes the RTs will just say, over Vocera, turn sedation up. So it's not just on nurses, it's the entire environment. But I know that nurses have a huge part to play in it and also suffer a lot from it.
Well, and I think we're making progress. And I've definitely seen that in the work that we've done at AACN. We're making tremendous progress in this. But I think what really helps us to make progress is hearing these stories. So I want to start to shift us over to Molly and Kaira and talk about the experience. And before we go down to our script, I really want to explain a little bit more about this story because I got to meet these ladies a couple of weeks ago. So after they met each other and they had this tremendous bond, we're all not going to cry today. They also found out that they have they were intersecting with each other's lives and had no idea until they met in the ICU and developed this bond. Yeah. And now Molly is actually engaged to be married, and Kaira is going to be her best maid of honor in the wedding. So just amazing. You can applaud a little bit. So Kaira, you were a champion in your ICU, and those champions are hard to find for this because this is hard and it's a scary thing to do. So what made you buy into it, and how did you start being that champion?
Yeah, well, I can only speak to my experience as a new grad in the ICU. So I was learning to be a nurse, an ICU nurse with 2 different specialties, neuro and surgical trauma. And then, it was a post-COVID world. And I remember Andrea Silva and Kaylee Dayton came to our hospital and really tested the boundaries of awake and walking. They were like, why is this person on sedation? And I think I was being taught by all of these nurses, we're creatures of habit, where we don't really know why, but this is the way that we've always done it. And really figuring out, okay, well, they're not tolerating the vent. What does that mean? Does it mean that they're anxious? Does it mean that their position? It's digging deeper. And I also think it was really helpful because we worked with the night shift as well, because night shift would just turn on sedation and then I would start all over on the day shift. And so really, I feel like my initial thing was so scary. I was like, oh my gosh, they're like coughing on the vent. I just need to get them calm. But figuring out that there was so many other avenues to work with getting these people on the least amount of sedation or just completely off sedation and awake and walking. And I think what really did the trick was it did start with the nurses knowing why and getting down to the root cause. But it also was the expectation of multidisciplinary team. It was the doctors advocating for that, making sure that we're turning off sedation right away in the morning. It was making sure that our RTs felt comfortable with it. And yes, adjusting the vent settings. PT/OT, actually, when they first came to our hospital, or not first came to our hospital, when they were there, they would only work with patients who were extubated. So that's something that changed as well, as they started to get familiar with working with our patients, even with the ventilators on. And then you have your charge nurses and your PCTs and everyone involved. And that's when I felt like the awake and walking and limiting sedation, I felt safe and everyone felt safe. And then we started to implement it and it got easier, and then everyone had their stories, and then sometimes it didn't work out. And that was also a learning experience in general. But I feel like where we really saw the aha moment of okay, this is gonna work, is we got a new hospital, and we had an old hospital at Lutheran. The rooms were cramped. The CRT machine, the ventilator, even if we wanted to get them up, we couldn't really do it. But we got a brand new hospital. Every single room was the same, with a lift, a recliner, the equipment gate belt, and everyone had equal opportunity to do that. And I feel like this whole change shifted. We had a new change of setting, and we were all capable of doing it. Not just ICU, but every single floor. We got so much better at implementing all of this.
And you just said that you were walking CRRT patients?
Well, not me at that time.
But now
I'm sure it could happen. But I'm just saying that we didn't necessarily work with them
Right.
as much because we were afraid.
Right.
Yeah.
And now you do.
And now we do.
Yep. That's the standard.
Awesome.
How do you maintain the momentum? That's what I would love to know. When you bring in new people or transfers from another unit, how are you working to kind of keep this, excitement and these patient outcomes, in the forefront of everybody's mind?
I think it really starts with, all of us know limiting sedation, getting people up is going to create better outcomes, and we've seen it. But I also think, specifically, like when I think about Molly and I's case, like I always tried to put myself in these patients' shoes, and you try to lead with compassion. But Molly was like a really direct example of, I really saw myself in her. We actually went to the same elementary school. We ended up figuring that out while she was on the ventilator. And you just think like, I wouldn't want to be doing that. How do we get her up to feel like herself again? And leading with that compassion. One of the stories that Molly loves to tell is when one of the first times that we got up, I was like, you're not going to like this, but we're going to get up and I'm going to put you in the recliner and we're going to go to the bathroom and you're going to brush your teeth and you're going to look at yourself. And she didn't want to do it, but I put on some music, like we were getting ready for a girls' night. And I'm like, that's how I would want to get up, you know? So, I mean, keeping that momentum, just keeping at the forefront that these people want to feel like themselves again. They want to look out the window. And that's when they really start to get better, is when they feel like themselves.
So Molly, I probably have more questions than we have time for. Your story is just absolutely amazing, first of all. So you found yourself at 23 years old with a massive stroke in the ICU. I mean, just wow. I can't even imagine. And then you're laying there, I'm sure you probably felt sorry for yourself. You're probably mad at the world. And your bops in, little happy nurse, and says, we're going to get up and walk. What was your reaction?
I just didn't want to do it whatsoever. I wanted to be in the bed. I had all of these things attached to me. I had an EVD in, so I had all this brain fluid, and over here was all these other contraptions that I didn't even understand, and wires coming out of me everywhere. And I didn't want to get up out of the bed. Like, I was not feeling like myself. I was not feeling great. And I just wanted to lay there. And Kaira came in and was like, no, we're going to get you up and you're going to get up. And I was like, how am I going to do these things with all of this stuff? And she got a CNA, and they came and they navigated all of the wires. And as soon as they got me up and I realized I didn't have to worry about that, I was like, I don't want to walk with my walker. So Kaira checked in with me and moved my walker, and I walked independently to the bathroom and started to get motivated. And I looked at myself in the mirror, I cleaned myself up a bit, and then instead of going right back to bed after, I took my time in the bathroom, and Kaira took me to the recliner, and I was starting to feel motivated. I was feeling like a human being again. And Kaira then, I had a craniectomy, and Kaira cleaned the blood out of my hair and put my hair up in a bun, and she found a way to have that time, but to make me feel like a human. And it meant so much to me, but it also meant so much to my family, who watched me go from, I'm a teacher, from teaching beyond full-time, coaching soccer, playing soccer, doing all of these things, to I was basically bedridden and I wasn't awake most of the time, to listening to music and washing my face, and my hair is clean, and I was having these conversations. So I went from being so hesitant to trusting, and all of a sudden, the more I felt like a human, the more I wanted to do. And eventually I was like, walk me down the hallway. I want to go up the stairs. I want to go down the stairs. My PT/OT team took me in a wheelchair downstairs outside of the hospital and had my family bring my dog to meet me. So I met my dog, and then I was so motivated, and I got out of the wheelchair and I walked up to the PT/OT gym, and they were passing the soccer ball with me, and I was dribbling in and out of soccer cones. And I went from, do not get me out of this bed, don't talk to me, to I want to go home and I want to do all of these things again.
And you also had a special skill coming into this situation. So can you tell us a little bit about how you know American Sign Language? So you were actually able to communicate better than most of our patients.
Yeah, so it was pretty awesome. My mom took American Sign Language classes in high school, and my entire life has worked at a deaf school, and she's currently the principal there. And I know a good level of sign language, but I know the alphabet, so I was able to communicate things. And before I was even aware, I was still on the vent, there were so many things that I was worrying about because I still consciously was there. I knew that I had to babysit on Saturday, and so I needed to communicate somehow that I needed someone to let the family know that I wasn't just blowing them off, that I wasn't going to make it on Saturday. So I was able to communicate. And then my favorite part of the story is I have 2 younger brothers. At the time, one was a sophomore in college at Marquette, and then my youngest brother was a senior in high school. And it was his last season of soccer. And so at the end of August, the brother that went to Marquette and we planned a surprise trip. And we booked it so that he was gonna come home, and he's a theater major, so he's so busy, but we wanted him to come home for a game. And so he was gonna come home for not our brother's senior game, he couldn't pull it off, but their rival game. And we booked this 2 months in advance, and it turned out that my stroke was the same week that he was coming out. And I am such a blabbermouth, like keeping a secret is so hard. So I started telling random people at work that my brother is coming so that I didn't tell anyone. So nobody knew, but I was signing to my family, like, brother, surprise, airport. And so then my brother reached out to my now fiance and told him, we still want to honor the surprise, but I need a ride from the airport. So then as soon as the babysitting was resolved or my brother coming, I would go back into this state where my body was sedating me itself. And I just would go to sleep, true rest, just kind of blackout stage. And then I would pop into little things and add to conversations. If Kaira was talking to my mom and explaining things and my mom wasn't understanding and I was getting frustrated, I would clarify for her. And I was just adding things, and I'm on the vent and I could tell them if I wanted my mouth sponged or scraped, and just simple things, because you just feel terrible, but then they sponge my mouth and I can rest again. And then maybe a few hours later, there's something else, but I was really able to settle.
It was so incredible because sometimes as the ICU nurse, you just see someone agitated and you're like, okay, pain, position, do you have to poop? Like, I was able to see that she had very complex things that she was worrying about. She was worried about her brother being picked up from the airport. Like, if she was sedated, I wouldn't have known that. And she was able to sign so many detailed things. Like, she thought she had to go to the restroom, but she had a Foley. So instead of just saying, oh, you have a Foley, we had to readjust the balloon. And, you know, she wanted her mouth sponged versus scraped. And just these little things that I was able to do because she could communicate on the vent was really eye-opening.
So I have a question about your experience, though. So how many days were you intubated for and on the ventilator?
I believe 5 of the days. So I was in ICU for 12 days and then hospital for 15, and 5 of them I was intubated.
Okay. And so then during the time you were intubated, you had no sedation. And so I think this is the part that scares nurses, is because we wonder, you know, are they feeling pain? Do you have enough memory of what you felt like? So maybe it would calm people's minds and nerves to know, like, what is the patient really feeling? Because we know some patients, you know, they can't tolerate it, they get very anxious, but how were you managing that sensation of having that tube in your throat, or just not understanding everything happening?
I used that communication to express what I needed. And the thing I really remember was just being in a blackout state, where time was going by, but I didn't have a sense of that because my body knew that I needed to rest. But I was uncomfortable at times, and I didn't understand what was happening. I didn't understand why I was restrained, and I didn't understand why anytime I tried to move my arm, everyone in the room freaked out. But I could start to understand that, and I knew I could open my eyes little bits and see that the people around me were my family and people that they trusted, so I knew that I was safe, despite having this overwhelming feeling down my throat. And I just wanted it out, and I wanted to drink water, and I wanted to talk, and it was so uncomfortable and sad, and it made me mad because my last memory was, I'm having a migraine and I'm gonna get medicine. I'll go home, and then I'll be back at work in a day or two, so I didn't understand, but I wasn't sedated, and they were able to explain to me that they were saving my life and what I had gone through and take those worries away from me. So I felt uncomfortable, but my pain was so managed, and my body knew what my body needed to do. My body took care of me in that time, and by not being sedated, I was able to rest, get better, and understand what I was going through.
Mm-hmm. Having spoken to dozens of survivors, those have been awake and those have been sedated and those have been both ways, that ability to communicate has a little bit of a little window as far as being able to sign. You're spelling out with your hands. That is a high level cognitive function on top of a brain injury that you're having. So if we'd added sleep deprivation from sedation, even for a day or two, that easily would have taken away her ability to sign, probably the fine motor skills to write. That wouldn't have taken away her concerns and her needs. It just would have taken away the ease to articulate what she needed, and it would have made Kaira's job so much harder. So that's the hard position of start sedation, deal with it later, take it off later when we're looking towards extubation, is now we have all these other challenges in communication, and then the nurse is kind of left alone to deal with it. And so I think figuring out those communication tools and the timing of having sedation off is the key to opening those doors for having sedation fully off, mobility, all those other things. But I think Molly makes a strong point. It's the communication.
And sometimes when you lose that window and you've lost some of the fine motor and those things, then what happens? Then we start developing anxiety and potentially agitation, which is not good for your ICP, right? Or your stroke or your blood pressure or anything. And then, so what do? We add more sedation on.
And some survivors have said they were very aware of wanting to communicate something very specific, and then the restraints going tighter and everything going black again. And sometimes the concerns they had were related to delirium. Like one survivor said she thought she was a fish about to be flushed. And she was trying to tell them, don't flush me, which sounds comical, but for her it was real. And so for everything to go dark with sedation being resumed, fed into I'm being flushed. And she was aware, she said, I would just come out every morning and they'd shove me down deeper again. And so that's not our intention as nurses, but that is the position we're put in when we can't communicate. But that inability to communicate is part of the trauma that our survivors live with.
Thank you.
Molly, one thing that this is reminding me of is we just recently recorded a podcast with a gentleman, Caleb Armstrong out of Dallas, who's done some tremendous research on trust and how patients and the caregiver team develop that trust. So what were you feeling as far as that? Because again, if they would have come to me and said, we're going to get you up and walking, I would have been like, you're crazy. What are you doing? How was that? How did you feel that trust? What did it feel like as a patient to trust the caregiving team?
It came from the relationship that specifically Kaira, being my nurse most of the time, built with my family. And she had developed a really strong relationship with my mom as we went through it, because my mom knows me so well and could tell Kaira when I wasn't being myself, right? Kaira didn't have a baseline to begin with, but my mom did, and my mom was there, and my mom could tell Kaira, this is not Molly, this is so not her. And I remember having memories of Kaira, and I have memories of Kaira's smell. So I knew how Kaira smelled before I even knew who Kaira was, but I knew when she was my nurse because I could smell her. And I had my OT, for some reason I was caught up on numbers when I was just exhausted, and I couldn't remember people's names. I didn't want to open my eyes to see their face, but I had my OT, she told me her birthday, and so I knew who she was because I had her birthday replaying in my head. And then eventually I knew their face. So there were these little things that people did that I started to recognize, and ultimately they all really focused on my family and how my family could be okay and be there. There was one night I was alone in the entire time, and someone was always there with me. And my family knew these people when I was not aware and able to even understand. And so as I started to come to and understand, I knew it was okay because my family trusted them. And I knew who they were because they've been supporting me throughout the journey. And now I just know what they look like. I know their name. And so it really came from my family being there, but it was okay for them to be there, and they were used as a resource.
That's so powerful. So incredibly powerful.
So I guess from your perspective as an ICU survivor who's clearly thriving, not just surviving, what would you want ICU nurses and leaders to really know about why this awake and walking really matters, especially or even when it feels hard to do and implement?
Yeah, I've been thinking about that, and I feel that there's really three things that stood out to me and really shaped my journey. And when I started to get better was when I started to feel like a person again, because you lose yourself in that bed. And there's days where you don't even know that time is going. And then you wake up and your eye is swollen shut and you have no idea what's going on. You can't touch your head, can't move your arms. And people started to do things to make me feel like a person again. And even telling me things like, Molly, you smell really bad. We need to do something about this. And I was like, oh, because I couldn't even recognize those things myself. Mm-hmm. But then I remember my first day when I was really conscious, my nurse, she recognized that I was just uncomfortable in myself, and she helped clean me, and she got lotion, and she put lotion on my elbows and my knees. And I think that was why I really remember that day vividly, because I started to feel like Molly again instead of someone separate that was just really, really sick. Mm-hmm. And so doing what can be done to feel like a person, and sometimes that's literally just having normal human conversations at times, and directing questions as I'm becoming more conscious to me instead of my family, and really listening to how I'm feeling. And so once I started to feel like a person, I started to get better. And then it comes down to the communication and being able to use sign language and have people there that were understanding, because then I was comfortable and I was able to rest. Whereas if I had been worried about my brother coming or worried about babysitting, I wouldn't have been able to go into that state of rest. And I would have been spinning on it in my head, not getting better, and really freaking out and getting worked up, and probably would have been sedated, right? Because I'm going to be reacting. I'm trying to get someone to listen to me. Mm-hmm. But they allowed me to. And if they noticed that I was trying to sign something, they would loosen my restraints a little bit so that I had a bit more range to be like, I need water, sponge my mouth, just little things to communicate. And then ultimately, all of that became possible because I had my family there. And my mom was there constantly. And she would go every single morning to rounds. And Kaira would then, afterwards, Kaira would come and explain to my mom everything that they said. But my mom needed to be there and needed to know what was going on. And my mom still talks about she loved because the amount of doctors decreased every day. Mm-hmm. And my team got smaller and smaller, so my mom knew that I was getting better. And she knew what was going on. Anytime a doctor came in, she was there to understand, because I didn't have the capacity to know what was happening. And my brother was there from Milwaukee, and I remember laying there and listening to him color. And I remember him crying when he was leaving by my bedside, and I was like, who's this cute dude by my bed? Like, what? I had no sense of like what was happening. And then I was like, oh, that was my brother. That was really weird. But it was just like, he was there, and my whole family was there. And then my dad was there. And my favorite story with my dad was I kept signing something and nobody could understand what I was saying. And I was getting mad and I kept signing it. And then my dad goes, I think she's saying discomfort. And I remember this because uncomfortable, I was worried I was going to misspell it and it was going to be too complicated. So he understood that I was saying discomfort and would come in and just validate and be like, I know, this really sucks, kid. Like, this is unfair that this happened to you. And he came and we watched the Bronco games in my bed, even though the speakers were in my bed, so I was the only one that could hear it. But he was there watching the Bronco game with me. And then my fiance was there, and it really just shifted our relationship. And he was there, and it showed, he sat in that room for weeks with my family, not knowing what was happening. And he went through this journey and supported me, and really also supported my family. There was one time my mom went to her car to leave for the first time in like 3 days, and she was just crying in the car. And he like pulled up next to her because he was like switching shifts, and he just looked over and he's like, I know. I gotcha. And they both just like had a moment in their car next to each other. And then my mom was amazing, but my youngest brother was there the whole time. And his high school was 5 minutes down the road. But I really loved Blue Powerade because for the longest time, the taste of water was horrible. And he brought me Blue Powerade whenever I wanted it, and vanilla Chobani yogurt. Because they kept telling me that if I didn't start eating, I was going to get a feeding tube, and I was not going to let that happen. And so he came, and he loved it because he got out of so many classes bringing me stuff. But he was there, and he brought this joy because I was just sitting in this room, and he would come and he would mess with me. And like, I was telling Kaira, even like after the hospital, we would wrestle, and he'd push my buttons and make me mad, and I'd be like, stop it. And he just brought me so much happiness, and having that community of people when things were really hard or I didn't understand what was going on, I had them to keep going and to support me. And if I was really didn't want to do something or something wasn't, I could ask them questions, my family could help me. So being a person, communicating in family was really what shaped my journey.
Can I ask Molly a question? There's this online, there are some discussions, videos, even memes about families touching patients and nurses wanting families to back off because they get a response. They get, quote, agitated. So what did it mean to you to have your family physically touch you, and what would you have nurses know about that kind of interaction with your loved ones?
It was really the way that I knew that they were there, especially in the earlier days, because I wasn't really understanding and hearing what was happening, and I didn't want to open my eyes. But they could come up to me and I knew that someone was there, and then I could listen and they would tell me who it was and they would sit there. I remember my grandparents drove in to be with me and my grandma sat and held my hand, and it just was very comforting and safe, because it was so much better when they were holding my hand than when someone else was doing something to me, and it allowed me to really relax and just know who was there when I wasn't able to process and see it.
Thank you.
Wow, this is just incredible. So I do want to turn it over to the audience. And if you have any questions, please make your way up to the mic, because we would love to hear any questions that you have. But I have to say, having children your age, I just can't imagine what your mom went through the first time you went out on the soccer field a couple of weeks ago. So
I
the
fell
fear
the first
of
time too.
What?
I fell over backwards and I was like, huh. I looked at them and I was like, I'm good. I'm actually fine. I can get back up and keep going. But they were terrified for sure.
So any questions from the audience?
How are you today? I love your story, by the way. It's wonderful. Our hospital is on a journey to have lessened restraints and to make sure, of course, that they're properly documented. What do you do to find the balance between having increased restraints because you have somebody more awake versus, trying to have an environment where you're lessening restraints?
So that is a very common question, and it totally makes sense, right? Because usually when we're taking sedation off, it's after a period of time that they've been sedated. And now a lot of times they don't know what's going on. The first instinct is try to self-extubate. So the difference here is, especially in an environment like Kaira's, is the sedation's off as soon as a paralytic wears off after intubation. And unless they are encephalopathic or have other impacts to their cognition before intubation, patients are more likely to know what's going on. And it's the delirium that really makes it hard to keep patients off of restraints. The ironic thing is that restraints can also exacerbate delirium and vice versa. So I think your team was new to this. You were very conservative, and now maybe Kaira wouldn't even have been restrained. But that's where it's an evolution of comfort to avoid restraints and really trust patients. But there's a time in which they're needed. So in that huge ABCDEF Bundle study from 2019, restraint use decreased by 60%, but not 100%. So the goal is to avoid delirium. And as we do that, with having them awake, communicating mobile early on, we'll be able to have more patients awake, safely knowing what their tube is. I've had patients write on a clipboard and say, be careful of my tube, which I think is a little bit offensive, but that's okay. But that's what we want them to know. So even things like post-intubation, having them see a mirror, allowing them to touch their tube, help position their tube to a place that's more comfortable. Orienting, you want patients to know exactly what that is, what it looks like, and how to be careful with it. That's much more likely to be successful shortly after intubation versus a few days later when they think that they've been kidnapped and that we're all their perpetrators and they're fighting for their lives. When that happens, then yes, we do have to use restraints, but we can also minimize the duration by avoiding sedation, getting them mobilized, and try to mobilize the delirium out, and continually circling back to, can we now take it off? There are also really great restraint innovations that are happening that can replace our traditional wrist restraints and allow for more freedom and movement. Because sometimes we treat a RASS of +1 like a RASS of +4. So looking at innovations to titrate our level of restraint while achieving the objective of keeping the tube in, but also allowing them to move and not exacerbating their trauma and delirium. So that's my complicated way of saying zero restraints is not safe either, but we can utilize the entire bundle to minimize the restraints and the duration in which we have them.
And what type of nurse-patient ratios do you have in order to do that?
What kind of restraints?
The nurse-patient ratio?
Oh, So in the environment that I come from, they've been doing this since the late 90s, and it was 2 to 1. And we had one CDA for like 16 patients, and it was not a super bulked up staffing ratio that you would think of. I've come to appreciate, having trained teams and walking through this process with them, that skill set does not just happen tomorrow because you just take sedation off. So I think it is really important for leaders to understand that they need extra time and resources, especially initially during phase 1, to figure out how to manage the lines and get them up and do those things. But we expect 1-to-1 ratios, which I don't think is going to happen for our country. And even in countries that do have 1-to-1 ratios, they still sedate their patients. So it's not just staffing ratios, but it is a consideration, especially even the patients that we give, right? Like we might be used to 2 patients that are vented because they're just rotisserie chickens. Now we change it to 1 patient is vented and they're awake and unrestrained. Another patient has no delirium, right? Like we're taking delirium and mobility needs into that staffing numbers, as well as which assignments we give our nurses to make sure that they are safe assignments. So it all plays into the bigger picture, but it's something you have to experience for yourself, as Kaira is attesting to, is when you get that standard culture of patients are awake right away. If sedation's running, we're all asking, why is that running? There might be a reason, but it's weird to have sedation running. When we get to that point, it's so much easier. That delirium is minimal. Patients are able to move themselves easier. It takes less people to move them, and they're more likely to know what's going on. And when you have those situations in which they are delirious, hard to mobilize, you're able to accommodate that more easily than if you go to your unit right now, turn sedation off of everybody, and everybody's confused and thrashing. That's what we're working towards avoiding.
Thank you very much.
Thank you.
Kelly, can you provide one point of clarification
Yes.
for nurses who may be newer to ICU in the audience, that minimizing or not using sedation doesn't mean we don't treat pain?
Yes, sedation and analgesia are 2 very separate interventions. And it's really important, like what Molly was articulating and Kaira was saying, that we understand why we're having this behavior. So if we don't know and someone's showing signs of distress, sometimes we assume it's pain and we turn up sedation. And that's not treating pain. So the A of the bundle, I invite people to consider it as ask, not just assess, but ask the patient if they're in pain and treat that pain. So that should be our top priority. Just because someone isn't moving and showing signs of distress under sedation, because they are chemically restrained, it does not mean they're not having pain.
Correct.
So yes, pain management is our top priority, and that's usually best facilitated when patients can tell us exactly what's going on.
Thank you for that clarification.
Yeah, thanks. That's a great question.
Hi, Katie Collin from University of Pennsylvania. This was beautiful. I really love the idea of nurses connecting with their patients after they care for them, and I think it's something that would fill our cup more, understanding the results of the care we deliver. One thing I'm thinking about is communication and how, we find patients with limited English proficiency are restrained at higher rates, sedated at higher rates. So I'm kind of like, is communication at the root of a lot of these issues? And so, Molly, we're so lucky to have a patient perspective here. What I'm thinking about is, if you could not do sign language, what could we have done as the care team to help represent your voice, especially in a case where we're using limited sedation to help, go through that process?
Yeah, I asked Kaira about that yesterday, because I was thinking it was such a privilege for me to be able to know how to do that, and then also have my mom in the room with me to really push that along. And Kaira was saying that if we are not sedating the patient, they have the ability to sit that patient up to allow them to point at things, or give them a piece of paper and a pen and just help them writing things. So finding ways that your patient can communicate, because the way I did was definitely a very lucky experience. So that's what we talked about.
And something that I like to have teams do is, before intubation, if we have a chance, we didn't in your case, but if you know what's coming, you have the chances, ask the patient what they prefer, pen or paper or cell phone, which right now may seem silly to you guys, because you're like, when I give my patients a clipboard, there's no way I know what they're writing. But if our goal is to have it off 2 hours later, they're much more likely to be able to write or text, and we can keep those tools simple. But then work with your speech language pathologist to make sure that you have a plethora of tools for when they're cognitively or physically impaired, to be able to find other ways to communicate. And there are, again, great innovations and apps that are available now to streamline that communication. So I think it's important to have a whole toolkit, and for you as nurses to know which tools are appropriate for which patient. But when you take this early on approach, the chances are most of them will be able to just write or text.
Yeah. And I think one other thing before I'm done, but I think that if patients are irritable, they might not be in pain. They might not be uncomfortable. It might be just because they can't communicate, So yeah, but thank you so much. This was really.
I have a whole list of things that patients have communicated just to me, or stories that I've heard that I'm like, I never would have thought of that as a yes or no question. Withdrawing from Wellbutrin, worried about their dog getting fed in their apartment, things that would not just go away with sedation, but we would probably never guess. My daughter has a lot of life-saving medications. You're not going to know me well enough to guess, but I'm going to wig out if that's not being addressed. So it's important for them to be able to communicate beyond head shakes, yes or no, that's a good place to start. But we need to be looking at tools to give them full communication.
Hello. So I work in a small community hospital where, we're working toward 24-hour, ICU coverage, but we're not quite there yet. So it's still kind of a system where when the day shift leaves, the night shift has to either call an on-call ICU intensivist who is not necessarily, up for kind of the rigors of an awake and walking ICU, and will kind of put people on Versed, propofol, everything, and then I'm coming back in the morning exactly with that face. And then to kind of to your point, my whole day has kind of been undone. And I know we're very committed to an awake and walking ICU, ambulating patients on ventilators. So as somebody who's kind of rolled out these, policies in different hospitals, I was wondering if you had any tips for, me as an APRN to help kind of promote that comfort as an RN in a area with limited resources and limited provider availability.
Well, if we're using things like a Versed drip to minimize resources, it's very backwards. So we actually know one of the biggest risk factors for self-extubation is Versed. So we're setting patients up for delirium. Delirium increases the risk of self-extubation by over 11 times. So if we're using that to prevent self-extubation, no, they're just setting you up for self-extubation on day shift. It's also extremely expensive. So I would take this to the hospital executive leadership team to say, we need overnight coverage, presence at least, right? And here are the financial benefits. This whole initiative, we know the bundle decreases costs by 30%. ABCDEF Bundle.com is a website just dedicated to the research on the financial benefits of keeping patients awake and mobile and the high costs of keeping them sedated. So if they're like, we can't afford to have a provider on at night or have someone there that can intubate, then say we actually can't afford not to. If we're sedating patients because we don't have a provider, we're causing a lot of costs, not to mention obviously we know mortality and harm, but use the research to leverage greater resources for your team, whether it's a provider at night, mobility, techs, equipment, whatever you need. As nurses, we're an evidence-based discipline. We should be using the evidence to advocate for evidence-based practices. So that would be my biggest plug, is to tell them how expensive it is.
Perfect. Thank you so much.
Thank you.
Hi, thank you for sharing that story. I was just curious, was there anything the team said during moments of confusion or anxiety that you felt while you were on the ventilator that felt meaningful to you or really helped you calm down in moments?
The big one I remember was I got a timeline for how long I was going to be intubated for, and they communicated with me what day it was. And when you're in the ICU, it's every single hour, so you start to lose sense of time. And they were communicating to me, okay, you're going to get extubated on Saturday morning. Right now it's Thursday afternoon. And then it would be, okay, we're shifting over to our night shift. And Kaira would say, it is Thursday night, we're going into Friday. And then Friday I would get the same information. So clearing those things up, because it feels like forever, you lose sense of time. And just letting me know what they were doing each time. And then I felt like I had control in my experience as well. And I knew what was coming based on the certain checks, and I knew to do my neuro exams, and I knew what was coming. I knew when I could just rest and they were just checking on something. So I knew what was going on. And as I became more aware, what they shared with me became more complex.
Thank you for that.
So thank you to both of you, or all of you actually. I've worked for the last 5 years on a DNP project on post-intensive care syndrome, and I actually spoke today at NTI. So my question for you is, Kaylee, if after the ICU period, okay, so you've done all this work, you've got people awake, walking, when they go out to the units, have you seen hospitals do anything progressive in that area, like continuing the work we've done on that A through F bundle in that post-ICU period while they're still in the hospital before they go home?
All of these departments, whether it's PCU, acute care, ED, even the IC, even the ER, the OR, they're all very connected and even codependent. So what we do in the ICU impacts what happens after the ICU, but even on these other floors, what happens before the ICU impacts what happens in the ICU, and we'll come back to bite them as well. And so this needs to be a hospital-wide initiative. There's a huge gap in post-ICU education. So acute care floors know very little about delirium. They're very behind on mobility as well. So what we do in the ICU, if we get them all tuned up, they can still go onto the floor and still get deconditioned. And so it's really important that they go in together. And I actually have another friend who works on doing the same kind of initiatives on the acute care floor, because that's not my expertise. And we're now coming in together to say, we're going to overhaul the entire hospital. When it comes to family education, I love innovations, right? There's another innovation, it's an app, familyroom.org, that's starting to help provide streamlined education for families that will help plant those seeds about post-ICU life, but it's an ongoing resource that they continue to learn about and be prepared for. But I always say, someone has acute kidney injury and they're still not at baseline by the time they leave the hospital, they follow up with nephrology. If they have ARDS, they follow up with pulmonology. When they have a sedation or a critical illness-induced brain injury, good luck. You got this.
I agree.
Right? And so there's such a need. So yeah, post-ICU, I love that we have so much going on with post-ICU clinics, but do they get pointed that direction if the acute care floor doesn't know?
You've got that gap, that however long gap, that 5 days, 7 days. And if you've had them up walking and then they go to the floor and they lay in the bed, we're deconditioning and we're back to where we started.
But historically, I've just been working on the ICUs, and then I'm planting those seeds saying, your acute care floors need to be getting up to speed as well. Here's my friend, I point, business-wise, here's a referral. But so I've seen hospitals be like, we're gonna start the acute care floor first, but the severity of delirium and weakness that we hand off to them is so tremendous that when these nurses have 4 to 6 to 8 patients themselves, they really can't. And we're sharing PTs and OTs between the ICU and acute care floor, which is a huge problem. But now we're pulling resources from the ICU because they have to go co-treat on the acute care floors. But what if we use that up front and prevent that level? Could we make it easier for the acute care floors to then carry that through? But so which comes first, the chicken or the egg?
Thank you.
Yeah, thank you.
I'm interested in scaling this from patient A to every patient, right? So what I really want to know is, how do you address the barriers to implementation? So if you can give me the top 3 barriers that you've encountered and how they're addressed, both with nurses and other staff like physicians.
So the barriers to no sedation.
Yes.
One of the biggest barriers is we keep trying to bring in practices. We keep trying to have a change in practices with a change in knowledge, belief, perceptions, and skill set. It's very backwards. We've done a train the trainer model for I don't know how many years. So we're playing the telephone game of this champion went to this university for a day or two, and now we're getting told to do these things and chart these things. So I think it's really important to do a refresh of, let's talk about why this is important. We have to debunk so many myths before we can even talk about touching that pump. So that's one of the barriers, is the knowledge gap. We have to know the why before we can get to the how, and then we have to know the how. There are skills like we're talking about nonverbal communication, agitation management, ventilator management. nurse-led mobility screening and implementation, that those are not skills. So we're saying do awakening trials, but we don't provide these other tools. So I think of it like a toolbox. We have one tool to manage agitation, that's sedation. We're not taking that away, we're just filling up the toolbox with all these other things. So they need to know the how. And then there needs to be standardized tracking, accountability, the order sets have to be in place. It needs to be really hard to do the wrong thing. I see intubation order sets having automatic sedation orders, right? Automatic restraints, all of the things are automatic. So I think providers should have to indicate the reason for sedation when they go to order it. I think an intubation order set should have sedation for the next 2 hours while the paralytic is on, and then it drops off. Now, if there's a reason for that sedation, we're gonna write an order for that. So there's just a lot of structural things in EHR, culture, skill sets, workflow that have to be adjusted to make this successful and sustainable. But sustainability is so much easier when we go all the way. I think about SATs and SPTs are like having your jet skis halfway out of the water. It's really hard and you have a lot of resistance, and you can only do it for so long. But awake and walking ICU, when they're awake, moving themselves, riding, delirium and weakness is minimized, that's like having your jet skis finally on top, or your water skis on top of the water, and you're finally cruising. And that's part of making it standardized, is taking a strategic upfront approach. Rather than just thinking about rehabilitation, we need to be thinking about prehabilitation. And then we're better equipped for rehab on the back end.
Okay, thank you.
Thank you.
Well, I hope I have a quick question. I was going to hit on the transition between critical care and then going down to the progressive cares units, and how that changed for you. We're working on our ICUs right now, and we work for large hospitals, so that is going to probably be another year or two down the road for our acute care units. With that being said, you hit on every bundle of the element, and the one thing that you did not say was that you got delirium. So my biggest question is, did you have any measure of delirium after all of these other interventions were implemented?
So I've thought about that, and I feel like the only thing I could say came close to delirium was when I was intubated. I thought someone was forcing me to eat balls of mozzarella cheese, and I just had this taste in my mouth, and it was probably because I felt full. And who knows if that even, it doesn't come close to the delirium a lot of patients go through. So that for me was the closest I could say, but really no.
We should have asked this. Any symptoms of post-intensive care syndrome?
Cognitive, physical, or psychological impairments?
No.
By the way, she was supposed to go to Craig, which is like a world-renowned rehab facility. And she had to wait 1 weekend for her insurance. And by the time they reevaluated her, she did not qualify for Craig, and she walked out.
I didn't want to go, so I qualified one day, and everyone was like, you have to go, you have to go. I'm like, I want to go home. And so insurance didn't look, and then I overcame those deficits 2 days later.
Yeah.
I told her that.
Forget teaching.
At NTI.
Molly, it sounded like you had a ton of family involvement that was so wildly helpful. Kaylee, what do we do for the patients who don't have that?
No, that's
nobody coming, or one person for 1 hour a day.
No, and sometimes family is not super helpful. So I think we have so many socioeconomic challenges in our ICU that hit our ICU so hard. One, I think the family education, having a streamlined approach of giving families the best chance to be helpful contributors is really important. And if they are just absolutely not present, I've had a lot of unhoused patients. It is utilizing some of our resources like sitters and utilizing them strategically, because sometimes it's like just sit in the room and just be there. But we can do so much for delirium prevention, cognitive engagement, some in-bed things that are simple that a sitter can do that might replace. It's not the same as having a loved one, but utilizing those resources. And I know that there's such an idolized resource, but again, using the financial benefits to advocate for it, understanding that if we do this now in the ICU, maybe we won't need them on the acute care floor at such high rates. So figuring out, some hospitals use students as in a strategic way to sit there and play Uno with them, to do little things that are within their little scope, but sometimes it doesn't have to be like a doctor-prepared physical therapist mobilizing them every time.
And one of the things that I had with my family support is someone came in with a therapy dog, and their therapy dog just sat on the bed with me and just had that. So I don't know, all hospitals are different. What people have access to is different, but that was something that really helped me a lot too.
And breaking up PT and OT, I know that's a whole hornet's nest, but I'm just gonna put that plug in. But from a nurse's perspective, having separate sessions, so you're having more people working with them, communicating with them, helping engage the family, teach the family, rather than just like that 20 minutes one time a day, breaking that up. But a lot of times they do that because they get in there so late because they've been sedated. It takes a lot of hands and skill. So if we do it earlier, we're taking that away. Also, they don't know if they can work with the patient, so that for billing purposes, they're like, we know if we both get in there, we both get our hours and our points in. So we as nurses can do a lot to help those barriers for our therapists so that we have more support for them with separate sessions. Thank you.
Thank you so much for sharing your story, and Kaylee for your continued ABCDEF Bundle work. I I think Lutheran's the closest hospital to my house, so thank you for traveling from Colorado. I was curious about that hospital and your environment, your leadership, Kaira, the team that you have, the tools that you've been given. You know, we can all think of barriers and that we want to remove. What sort of setup did you have that allowed you to connect so, profoundly with your patient that would allow you to do that the next time?
I think it's the new hospital. Everyone had the same opportunity, a big room with a lift, a recliner, all of the equipment in there. So, the old hospital, we weren't able to do that with every patient, but everyone had the opportunity there. Another thing it wasn't just me as the nurse, it was the doctors coming in and being like, hey, I kind of want to get them up today. PTOT working with the intubated patients, and they go on the floors. RT has to be on board as well. And then also it was incentivizing because this hospital has window views of all of our mountains. And so it's also the patient wants to get up and look at a view too. And once you have all those multidisciplinary teams, if I'm not able to do this, my charge nurse can help me with another nurse, or the PCT's still comfortable. So it wasn't just me. It was everyone had to be on board for now my routine and for this to be a standard now. Now I think about my day and I'm like, oh, you didn't get your patient up? Like, it used to be, that was the exception, and now it's just everyone's routine. Yeah.
And having a way to track that throughout the unit. So you should know, the charge nurse knows who's vented, how many Foleys you have, who has a central line. They should also know who has delirium, who has sedation running, what level of mobility they're capable of, what the plan is today. So if I have to go down to MRI with my patient, the charge nurse can jump into the CNA and help my other patient up. But right now, you go in, you have like 26 patients, and you have no idea who's appropriate, who's not. We have to have really strong clarity so that the entire team can help and really be a team.
Well, I think today we've really heard a mix of evidence, the patient story, and the nurse story, which is always a wonderful way, I think, to tie it all together. So thank you to all of you. A special thank you to Molly for coming all this way. She lives in Colorado, so she made a special trip out here just to spend this time with us. So she's a little bit of a sports buff, okay? But thank you from the bottom of our hearts for coming and doing this with us. It's such a blessing to us as a nurse to see these practices come to life. So thank you.
Thank you.
We invite our listeners to send any feedback on this podcast or any future podcast ideas to AACN or podcasts@aacn.org. Thank you.
Well, join me one last time in thanking Kaylee, Kaira, Molly, Andrea, and Vicki. We really do appreciate it.
Thank you for listening to the American Association of Critical Care Nurses Voices in Nursing podcast, proudly sponsored by the ECMO course, providing nurses with a comprehensive understanding of extracorporeal membrane oxygenation, with information available at www.aacn.org/ECMO-course.